Welcome to the deep dive. We take the source material, you share the research, the reports, and really cut straight to the essential knowledge you need. Fast.
Trying to get to the heart of it quickly.
Exactly. Today, we're plunging into a really critical area of surgical practice, finding the best way to prevent infections during hip and knee replacement surgery.
It's a major challenge.
It is, and it involves this significant trade-off, doesn't it? How do you maximize protection against potentially devastating infections, but also carefully manage the risk of, well, serious drug side effects?
Precisely. So it's a constant balancing act in clinical practice.
Our source today is a research paper. It's from the Royal National Orthopedic Hospital NHS Trust, published on an official government website. It looks specifically at changing the antibiotic protocol used, before and after surgery in primary joint replacement.
Total joint arthroplasty, yes.
And joining me is our expert guide, Prof. Mo Imam, to help us navigate these complex findings and understand what they really mean.
Happy to be here. Preventing prosthetic joint infection, or PJI as we call it, is absolutely paramount in orthopedics.
I can imagine.
It's a complication that is truly devastating for the patient, and it presents enormous challenges for the healthcare system, too. Choosing the right antibiotic prophylaxis isn't straightforward at all. It needs a careful balance of efficacy against those potential adverse effects.
Exactly. And this study gives us some real-world data on that very balance. So at this hospital, they changed their standard antibiotic regimen. What was the old approach, and what did they switch to? And crucially, what were they actually measuring, both the good and the bad, so to speak?
Right. So the standard prophylaxis was initially Cefuroxime only, a 3-dose regimen.
Okay.
They then switched. They moved to a single preoperative dose combining 2 drugs, Teicoplanin plus Gentamicin.
A combination therapy.
Yes. And the main goal, of course, was trying to reduce the rate of prosthetic joint infection, PJI.
Makes sense.
On the flip side, the primary potential harm they were specifically tracking was acute kidney injury, AKI, which is a known risk associated with aminoglycosides. Gentamicin is one of those.
Okay, let's unpack how they actually studied this change then. What kind of approach did they take? How did they collect the data to compare these two regimens?
Well, this was a retrospective study, looking back at what happened.
Using past records.
Exactly, comparing outcomes in 2 distinct time periods, but at the same hospital. They looked back at all patients undergoing primary hip and knee replacements. The pre-intervention group, that was patients from the 18 months before the antibiotic change. They got the cefuroxime.
Right.
The post-intervention group were patients from the 18 months after the change. So they received the teicoplanin plus gentamicin.
Got it. And how many patients are we talking about?
They analyzed data from just under 2,000 patients in total, about 1,100 in the cefuroxime period and around 880 in the teicoplanin plus gentamicin period. And importantly, all the information came from routinely collected clinical records, real-world data. And to ensure consistency, which is vital, they used standard, widely accepted definitions for the outcomes. The European Bone and Joint Infection Society criteria, EBJIS, for diagnosing PJI,
Right.
and the kidney disease, improving global outcomes, KDIGO criteria for defining and staging AKI.
So, established definitions, real-world results.
Precisely, a pragmatic look at what happened after the change.
That approach, using the hospital's own data, it feels very relevant. But whenever you compare groups from different times like this, you have to wonder if the patients were, well, truly comparable.
Absolutely.
Were there any significant differences between the group getting cefuroxime and the group getting the new combination?
That's a very important point, and the authors definitely addressed it. They compared a whole range of baseline characteristics.
Like what?
Things like age, BMI, the ASA grade, which is a measure of overall health comorbidities, how long the surgery took, whether it was a hip or knee.
Crucial factors.
Yes. And for most of these, the groups were actually quite similar.
But not identical.
Not quite. There were 2 statistically significant differences they found. The cefuroxime group, the earlier group, had a higher proportion of female patients, and also more cemented arthroplasties.
Cemented versus uncemented. That can matter, can't it?
It can sometimes influence risk profiles, yes. So because of these differences, sex and cement use, they couldn't just do a simple comparison of the raw numbers. They used statistical modeling, Cox regression analysis specifically.
To adjust for those factors.
Exactly, to adjust for the potential confounding effects of sex and cement use, which allows for a more sort of like-for-like comparison of the PJI risk that you can attribute to the antibiotic regimen itself.
Good. So they tried to level the playing field statistically. Right, let's get to the core question then. the infection rates. How did the two antibiotics actually compare? This is where we see the potential benefit, presumably.
Absolutely. And the results here were, well, pretty striking.
Okay.
Across the entire group, nearly 2,000 patients followed for 2 years. The overall PJI rate was 1.50%. So 30 patients in total.
Okay, overall. But by group.
That's where the difference shows up. The cefuroxime group, the ones on the older drug, had a PJI rate of 2.24%. That's 25 infections out of about 1,100 patients.
Right, 2.25%.
Then, the Teicoplanin-Gentamicin group, their PJI rate was just 0.57%.
0.57.
Yes, only 5 infections out of 880 patients.
Wow. That is a dramatic reduction just looking at the raw numbers.
It is a very noticeable drop in the observed infection rate.
So, after they did that statistical adjustment you mentioned, for the differences in the groups, what was the estimated size of that risk reduction?
Well, after adjusting for sex and cement use, the analysis showed that the Teicoplanin plus Gentamicin group had a 75.2% lower risk of developing PJI compared to the cefuroxime group.
75% lower risk?
Yes. The hazard ratio was 0.248.
Okay, explain the hazard ratio a bit. What does 0.248 mean practically?
It means that patients getting the new combined regimen were, at any given time point during the follow-up, only about a quarter as likely to actually experience a PJI compared to those on cefuroxime, once you've accounted for those other factors like sex and cement type.
Right, so a fourfold reduction in likelihood, roughly.
Roughly, yes. And this difference was highly statistically significant. The p-value is 0.004, very unlikely to be due to chance.
A 75% reduction is really substantial. Was this benefit seen across the board for all types of infections, or was it particularly effective against certain bacteria, or maybe infections appearing at specific times after the surgery?
That's a critical insight from the source, actually. The risk reduction was, and I'm quoting here, most pronounced for early onset and delayed infections.
So infections happening relatively soon after surgery or within the first year or so?
Typically, yes. And specifically those caused by 2 groups of bacteria: coagulase-negative Staphylococci (CONS) and cefuroxime-resistant Enterobacteriaceae.
Okay, CONS and resistant Enterobacteriaceae. Why those particularly?
Well, it makes perfect sense when you look at the antibiotics. Cefuroxime, it's a second-generation cephalosporin. Its activity against many strains of CONS is limited, and it often has poor activity against Enterobacteriaceae that have developed resistance mechanisms.
So it had known weaknesses?
Exactly. Teicoplanin, on the other hand, gives excellent coverage against gram-positive bacteria, including staph like CONS. And gentamicin provides strong coverage against many gram-negatives, including most Enterobacteriaceae.
Ah, so the new combination directly targeted the bugs that the old drug wasn't hitting effectively.
Precisely. It covered the gaps. And these are common causes of PJI, so the new combination addressed pathogens the previous single agent was less effective against.
That's a really key point. It wasn't just a general improvement, it seems specifically effective where the previous antibiotic perhaps had a blind spot. So connecting this back, what's the main implication for why the infection rate dropped?
The authors conclude that this change in the antibiotic prophylaxis is the most likely reason for the lower infection risk.
Because of that better coverage.
Primarily, yes. Better coverage of key pathogens often picked up around the time of surgery. And this was alongside the hospital maintaining consistent general infection prevention and control practices throughout both study periods. That's important too.
Right, it wasn't just the drugs changing in isolation.
No. It's also interesting they note this finding contrasts with some older studies, trials that didn't necessarily show one regimen being clearly better than another.
Why might that be?
The source suggests it might be because those older trials often compared regimens with only minor differences in their spectrum of activity, whereas this switch involved a much more substantial change in coverage, specifically targeting resistance patterns relevant to PJI.
So a bigger change led to a bigger effect, potentially.
Potentially. They also raised another possibility about cefuroxime dosing, particularly in obese patients.
Blender dosing.
Maybe. They noted that a really striking 96% of the infections in the cefuroxime group occurred in obese patients, compared to only 40% in the Teicoplanin plus Gentamicin group.
96%, that's huge.
It is. It highlights that maybe dose adequacy for certain patient groups against specific bugs could have played a role in the higher infection rate seen with cefuroxime in this study.
Fascinating. So a significant drop in infections, likely due to better targeting of common and sometimes resistant pathogens. Okay, let's look at the other side of that balance sheet now, the potential harms. What about the acute kidney injury, the AKI?
Yes, the AKI. As you'd perhaps anticipate with using an amyloglycoside like gentamicin, the rate of AKI was higher in the group getting the combined regimen.
How much higher?
Well, the overall AKI rate across the whole study was just under 2%, 1.9%. In the Cefuroxime group, it was low 0.8%, only 9 patients.
Okay.
But in the Teicoplanin plus Gentamicin group, it was significantly higher, 3.3%. That's 29 patients. And that difference was statistically significant.
Right, so a definite increase. But you mentioned earlier that AKI has different stages of severity based on those KDIGO criteria. Was this mostly severe kidney injury or milder cases?
That's a crucial distinction, and the source is clear on this. The vast majority of the AKI cases, they saw 84% of them, in fact, were stage 1 AKI.
Stage 1 being the mildest form.
Yes, the mildest form. And the rate of stage 1 AKI was significantly higher with the Teicoplanin plus Gentamicin, 3.0% versus only 0.5% with Cefuroxime. That drove the overall difference.
Okay, mostly stage 1. What about more severe stages?
Importantly, the study found no difference in the rate of stage 2 AKI between the groups. And critically, no patients developed stage 3 AKI, the most severe form, in either group.
That's reassuring.
Yes. And furthermore, no patients required renal replacement dialysis for their kidney injury during the follow-up.
So, more common, but generally less severe and seemingly reversible kidney issues.
That's what this study found. And it's consistent with findings from some other studies using similar combined antibiotic regimens. An increase, but predominantly in mild AKI.
Were there other significant potential harms discussed in the source?
Yes, anaphylaxis. A severe allergic reaction. It was highlighted as a critical perioperative risk. And antibiotic-related anaphylaxis is certainly a known, though rare, concern.
Right.
The source references data from the UK's 6th National Audit Project, NAP6, which estimates anaphylaxis incidence during anesthesia.
And what did that show for these drugs?
Well, for the antibiotics we're discussing, NAP6 estimated incidences per 100,000 procedures. Teicoplanin actually had a highest estimate at 16.4. Compare that to cefuroxime at 0.9 and gentamicin at 0.6.
So teicoplanin potentially carries a higher background risk according to that national data.
According to NAP6, yes. But what's particularly notable from the source, from this paper, is that their own observational data within their hospital suggested the actual rate for teicoplanin anaphylaxis might be even higher.
Really? Higher than the national estimate?
Potentially up to 3 times higher than the NAP6 estimate.
Yeah.
Your local data suggested a range between 1 in about 2,100 and 1 in about 1,650 cases.
Wow. That raises questions about underreporting, perhaps.
It does raise questions. The source does point out, though, that administering teicoplanin slowly, usually over 30 minutes, is the recommended practice. That helps minimize infusion-related reactions, which can sometimes mimic or contribute to anaphylaxis symptoms.
Okay. This really brings us to the central question, doesn't it? You weigh that substantial reduction in devastating infections.
Which are terrible for patients.
Absolutely. Against the increase in mostly milder kidney issues and this potentially higher risk of a very serious, albeit still rare, allergic reaction like anaphylaxis, how do those benefits and harms actually stack up? How did the paper frame it?
They provide a calculation, sort of a thought experiment, to help put this trade-off into perspective. Based on treating 10,000 patients undergoing primary joint replacement.
Okay, per 10,000 surgeries.
Switching from cefuroxime to teicoplanin plus gentamicin could lead to an estimated 125 fewer PJIs over 2 years.
That's 125 fewer major complications.
Yes. However, it could also result in approximately 220 more stage 1 AKIs.
Okay, 220 more cases of mild kidney injury.
Predominantly mild, yes. And using a combination of the NAP6 data and their own higher local estimate for teicoplanin risk, potentially 5 more cases of life-threatening anaphylaxis.
5 more anaphylaxis events per 10,000.
That's the estimate based on their data and NAP6. So what's fascinating here is seeing that balance laid out with numbers derived from their real-world practice.
It certainly is.
It presents a very clear clinical decision point for hospitals and clinicians. Reducing one significant risk appears to come with increasing others, albeit potentially less severe ones in the case of AKI, but very severe in the case of anaphylaxis, even if rare.
That really sharpens the perspective on the decision. Every medical intervention involves that risk-benefit analysis. What were the limitations of the study that the authors themselves acknowledged?
Well, as is typical for a retrospective study, looking back in time, they noted several limitations.
Such as?
The inherent nature means you can't control all variables, like in a prospective trial. While they adjusted for those key differences like sex and cement use, they acknowledged that minor, unmeasured differences in patient comorbidities, or even maybe changes in the prevalence of certain bugs over the two time periods, can't be entirely ruled out.
Right, you can't control everything historically.
Exactly. They also mentioned it's impossible to completely isolate the effect of the antibiotic change from other potential historical effects. Maybe other subtle changes in practice at the hospital during that time, although they did state that general infection prevention practices remain consistent.
Okay.
And finally, the incidence of some very specific resistant bacteria, things like vancomycin-resistant Enterococci VRE, was just too low in their data set to draw firm conclusions about the impact of the new regimen on those particular pathogens.
Understood. So given these findings, the clear benefits and the clear risks, and acknowledging those limitations, what's the main takeaway message for professionals, say orthopedic surgeons or hospital pharmacists reviewing their own prophylaxis protocols?
I think the key conclusion from this single-center observational study is pretty clear. The change to Teicoplanin plus gentamicin was associated with a significant reduction in the overall rate of prosthetic joint infection. And particularly, it targeted those early and delayed infections caused by Con S and cefuroxime-resistant Enterobacteriaceae. That seems key.
What?
But this benefit came with a statistically significant increase in acute kidney injury, mostly the milder stage 1 cases. And it requires very careful consideration of the potentially increased risk of anaphylaxis, especially given the local risk estimate for teicoplanin being higher than national figures. So the decision for other hospitals really involves carefully weighing these specific quantifiable benefits against these specific quantifiable harms, all within their own local context, their own patient population, their own resistance patterns.
And linking this to the bigger picture, the source mentions the importance of prospective multi-center studies following this kind of single-center data. Why is that next step crucial?
Well, prospective studies are really essential to confirm these findings in a more controlled environment across multiple different centers, which would include varying patient populations and potentially different local bacterial resistance patterns.
Get a broader view.
Exactly. They can provide more robust data on less common outcomes, like severe AKI or anaphylaxis. And importantly, they offer a better opportunity to monitor the impact of these antibiotic changes on wider trends in antimicrobial resistance over time, which is, of course, a major global health concern.
So this study provides compelling real-world evidence from one place.
Yes, strong observational evidence.
But confirmation and broader applicability really need those larger prospective trials.
That would be the ideal next step to inform wider practice changes confidently.
Okay, so we've taken a deep dive into this really interesting study comparing two different antibiotic approaches for hip and knee replacements. We've seen that switching the regimen at this particular hospital led to a significant reduction in those dangerous prosthetic joint infections, especially hitting the bugs that the previous antibiotic struggled with.
A clear benefit on the infection front.
But we also saw that clear increase in kidney issues, mostly milder, thankfully, and that potentially higher risk of a severe allergic reaction, anaphylaxis.
The trade-off is very evident.
This study powerfully illustrates that real-world balancing act, that trade-off that hospitals and clinicians have to navigate constantly when deciding on the best strategy to protect patients. If you found this deep dive valuable, it really helps other professionals discover these insights if you consider rating and sharing the show.
Getting the knowledge out there.
Indeed. Thanks for joining us for this deep dive. And just a final thought to leave you with. Thinking about the specific bacteria that this new regimen was particularly effective against those resistant to the previous antibiotic, does this study really hint that tailoring antibiotic prophylaxis strategies much more closely to local resistance patterns is perhaps the most impactful way forward, even if it means consciously accepting and managing different types of risks, something to perhaps consider as you review protocols in your own clinical setting